Hello everyone, today we are going to start the USMLE practice question about the public health, biostatics and epidemiology. Today, first question is totally about public health and we are going to about that is observational study types. So a group of investigators are studying the effects of transcranial direct current stimulation, that called TDCS, on cognitive performance in the patient with Alzheimer's disease. A cohort of 50 patients with mild Alzheimer's disease were randomized 1:1 to either TDS or SAM-TDS over temporal parietal cortex. The both procedures were conducted on the patient experienced the same sensation while receiving treatment. After 2 weeks of the treatment and the neuropsychiatric testing to assess the recognition memory in a 1 week of observation during which no treatment were delivered, the treatment in each group was changed to the one used in another group. The treatment is going to change. The neuropsychiatric testing was subsequently repeated, which is the following best describe the study design. Guys, in this we have to describe the study design. First, evaluate the study design. If you focus, they mentioned after the 2 weeks of the treatment and the assessment, they are going to 1 week of observation with the no treatment and the treatment in each group were changed. So this is one type of effect that can occur during the washout period. The washout period is between the treatments, commonly including crossover studies, to enable any effects of the first treatment to wear off prior to starting the sequential treatment. So this effect is going to shown in crossover study. So our answer is a crossover study, and in crossover study every participant receives all the interventions but at different times or in different sequence. In a study describing this explanation, in all explanation, all the participants sequentially received the TDCS and sham TDS. The groups crossover and there's a washout period between the treatments is commonly including for a crossover study to enable any effect of the first treatment, and the crossover designs are best suited to study intervention with the temporary effect of the chronic disease with a stable state during the study period. They are not suitable for the studying acute conditions. Okay, they are mostly suitable for the chronic conditions. And when we are compared to other RCT variants, the advantage of crossover study, we talk about the advantages of the crossover design. There is a low risk of confounding bias, and secondly, in this type of study, there is an increase in statistical power as happened due to doubling of a sample size with the same number of participants. And if you talk about the disadvantage, include a long study period, having a long study period, and whenever any research or any study having long study period, then there is a high risk of resulting increase in dropout rate. Understand, if we talk about the other options like a meta-analysis, the meta-analysis results in a multiple similar studies that are pooled and analyzed in order to improve the statistical powers. But in this treatment, we are only get single study. Okay, now talking about the second option, that there was a case control design, is the observational study in which the particular risk factors is retroactively assessing two groups, that is tracking according to the presence and absence of particular outcomes. But in these studies, they described here where the participant received only TDCS and sham TDS. If we talk about pretest poster study design, in which there is a data is collected before and after the interventions, like new teaching method, administration of new drug, in order to study the effect of intervention, all the participant of the pretest received the same single intervention. But in the statement, there's a one group received TDS, another received sham TDS. If you talk about the factorial study test that affect having a two or more interventions, but in according to our statement of question, they describe the testing of effect of only one intervention, that is TDCS. TDS stand for yes, it's a transcranial direct current stimulation. And if we talk about the parallel design, that participants are randomized into different groups. Here is a treatment was suppressible, but in our study, the participant in the study having the switch groups. After a week of experience, both intervention, this is not a parallel group study now. We will move to our next question. The next question is about a group of investigators who are studying individual infected with a triposomal CROZ and is evaluating the real-ESA absorbance cutoff value of the CM sample diagnosis of infection. The previous cutoff points is found to be too high researchers decide to lower the threshold by 15%, which the following outcome is the most likely to result from this decision. Okay, in this question they are saying if we decrease the threshold value, which is the outcome, that following answers which will be correct and the most likely result from this decreasing a threshold. First we have to go with this diagram. Okay, for example, if you know about this graph, this is a test cutoff values. The values are here that are true, negative, and here is a true positive. In between is a false positive, and this overlapping is a false negative. So this true negative is about the negative predictive value. So if you will decrease this part, you will decrease the test cutoff value. Obviously there will be increase the negative predictive value. How it will be the negative predictive value of the test is likelihood that individual with the negative test does not having the condition. Okay, we will write here separately. First is about the negative predictive value. What about a negative predictive value? It is a likelihood that negative test result does not have the conditions being tested. Negative predictive value means no disease with negative test understood. And then these conditions are being tested. Negative predictive values are calculated as true negative divided by the sum of true negative plus false negative. Understood? And for this test, like ELISA, absorbance value must meet or exceed a specific threshold to establish a diagnosis or imposoma cruise infection. Lowering the threshold here, if we decrease this cutoff value of this tail, will lead to decrease the number of negative test results among the infected individuals. For example, this was the value of negative. Okay. When you decrease this part, then they will also decrease the number of negative tests. Understand, we will make this point and this will be negative test. It will be decreased the number, understand, among infected individuals. If the test produce fewer false negative results, then the NP value will be increased, and negative test results the most likely reflect the individual diagnosis of the infection. Understand? So if you make a common thing in this graph, if you decrease the cutoff value, the negative predictive value will be increases because there will be decrease in number of the negative tests, and loading the threshold for this test will also result in increasing sensitivity. There will be decreasing specificity, and there will be decreased positive predictive value. Most commonly these four terms are we using. The negative predictive value will be increased if you decrease the threshold. Sensitivity increased, specificity will decrease, and there will be decreasing positive predictive value. Okay, let's check the right answers. There will be increase in positive predictive value. No, there will be decrease in positive predictive value. There will be increase to negative results. No, there will decrease in two negative results. There will be increases. There will be increase in specificity. No, there will be decrease in specificity. There will be increased negative predictive value. Yes, there will be increase in negative predictive value. There will be decrease in sensitivity. No, there will increase sensitivity, and there will unchain true positive result. No, it will be decrease. Understand? So now we are moving to the next question. The next question is about an investigator. An investigator is studying nosocomial infection in a hospital. The weekly incidence of a hospital-acquired pulmonary infection within the pediatric wards of the 8 different hospitals reported. The results are shown in this graph. Which of the following values best represent the median value of incidence rate? Okay, in this graph we have to go for the median value. For the median value, you have to arrange all the data that is given here. Okay, the median divides the upper half of the data set from the lower half. That is a 50% of data set lies below the median value and 50% lie above it. Like this is a one full, and this one, the median 50% here and 50% is here, like that. When we arrange in order of magnitude the data set in this equation, let me show you focus. They're having 8, it's having 3, 7, 5, 7, 1, 4, and 9. So we will make an arrangement, arrange position. It will become 1, 3, 4, 5, 7, 8, and 9. And if you make a sum of this number, that is 1, 2, 3, 4, 5, 6, 7, 8. This is a total 8 number. So when there is the median or this even data set, you will make the average of two middle values. What are middle values? These are 4 and these are 4. This is a middle value. So make a sum of middle value 5 plus 7 and we will divide by 2 and it will be 12 divided by 2 and it will be equal to 6. So our answer will be 6. The 6 is median value, and if we talk about the mod is a most repeating number. What will be the mod? The mod will be 7. 1 to 2 times 7 is common. Understand? And if we talk about the mean, we will make a sum up of all the values. It will become about 44 and we will divide about the number that was 8. So 44 divided by 8 will be equals to 5.5. It will be our mean. Understand? Now we will move to our next question. Our next question is about a 62-year-old man's come to the office and his office with the epigastric pain, flatulence and 1.4 kilo weight loss over the past 6 months. He immigrated to the United States 2 months ago. Prior to that, he had always lived in Nigeria, which has an overall prevalence of H. pylori infection of 85%. The patient given an urea breath test for suspected H. pylori infection and the results is negative. The urea breath test has a sensitivity of 90% and the specificity of 96. The physician finds an article on the performance of the urea breath test in the primary care patient in Nigeria who present with a symptom of dysplasia. The results of study shown are here. So which of the following formulas best estimate the likelihood that patient did not have H. pylori infection? For this they make the group maybe I have. No, I did not have here. So the best method for this, whenever they are giving any question in the public and regarding, you have to make one table. You have to make like 1G squared table in which you have to mention the disease. And here you have to mention the test. And here there is a positive, negative, they don't have disease. Their test is positive, their test is negative. If we talk about the patient with the infection and positive, that is 1495. 1495 are true positive. They're having disease and their test is positive. Then if you talk about the patient don't disease but tests are positive, are 4. So there will be false positive. It is a false positive. Now the patient having the disease but test is a negative, that are 55, and that are false negative. And at 94 are true negative. The test is negative and they don't have disease. So what we have to find, we have to find the likelihood. We have to find the likelihood ratio. About what thing we have to find? Which of the following best estimate the likelihood that the patient that knows have H. pylori infection? When we are talking about calculation of notion disease, they're having no disease. Mean they are talking about the non-predictive value. Understand? Negative predictive value. You guys know negative predictive value means the patient don't having disease. So it is the proportion of a negative test result that are true negative. In this scenario, the test negative predictive value is the likelihood that the patient with a negative test of H. pylori infection in which H. pylori negative test truly does not have the disease. So if we calculate the negative predictive value, we already know we're having the formula that true negative divided by sum of true negative plus false negative. So we will put the values. True negative is 94. True negative is 94 and the plus false negative that is 55. So we're having that option. Yes, we're having that option. The answer is right. The 94 over 55 plus 94. So this question we have to find negative predictive value. Negative predictive value having the formula true negative divided by sum of true negative plus false negative. Understand? But don't forget it's a very important technique to solve this question. First, make the type of a table so you can guess which is the value of a true positive and which is the value of a true negative. Now we are moving to our next question. Our next question is just about a clinical trial that is conducted to determine the efficacy of ginkgo biloba, the treatment of Parkinson's disease. It's a sample of patients with Parkinson's disease divided in 2 groups, and that will happen. The participant in the first group is treated with the ginkgo biloba and the participant in the other group receive a placebo. A change in the Movement Disorder Society Unified Parkinson's Disease Scale score is used as a primary endpoint of study. The investigators, participants, and the data analysts were meant to be blinded throughout the trial. However, while the trial is being conducted, the technical flaw disclosed. The participant demographic and their allocated groups to the investigator but not to the participant themselves or the data analyst. The study concluded there is a significant decrease in MDS-UPDR score in the patient treated with ginkgo biloba. Which of the following the most likely to have affected validity of this study? So we have to describe the points like which of the following of this thing having affected the validity of study, which type of bias is there. So the main thing, according to me, this statement in which they are saying, however, from this here, this, however, while the trial is being conducted, the technical flaw disclosed. This is the participant demographic and they are allocated group to investigators. So when the investigator know the participant which is getting the medicine or drug, so there will be obviously observer expectancy bias will be there, which observer expectancy bias will be there. Mean to the investigator is doing research, so they will be little bit biased toward their own drugs, like the patient taking drugs, so it will give a good effects. So it is called the observer expectancy bias. The other name of this bias is like Macmillan effect. So right answer is the Macmillan effect. That's the phenomena in which the investigator expectation influences the outcome of the study. The investigators believe in the efficacy of the treatment with ginkgo biloba maybe have influenced the data collection to avoid, despite the study didn't have to include placebo groups for them. We are having placebo groups to reduce this effect. We have in the placebo groups and the investigator need to blind it throughout the study. But here the investigators are not blinded. Understand? Now we are moving to our next question. And the next question is on a calculation. As 26-year-old medical student come to the physician with a 3-week history of a night sweats and amalgam. During this time, he has also had a 3.6 kilo weight loss. He returned from 6-month topic medicine rotations, Cambodia 1 month ago. A chest X-ray shows a reticulonodular opacity suggestive acute tuberculosis. The students are curious about it likely having active TB. He reads the study that compares sputum testing results between 200 patients with likely active TB on the basis of their history, clinical symptoms, and chest X-ray pattern and between 200 controls. The results are shown here. So we have to do which of the following: the likelihood that the patient with suspecting active TB on the basis of a history, clinical symptom, and chest X-ray actually have active TB. In this we have to give the positive predictive value, because now they are saying about the suspected active TB. So already we are talking previous question when they are saying we have to give a likelihood that patient don't have disease. You will go for the negative predictive value, but now they are saying about the suspected active TB. So now we will find positive predictive, understand. And if you guys know the positive predictive value also having the formula, and it will be also same with negative predictive value, how it will be like they having the true negative. So here we having true positive, okay, and in the last we're having divide with the sum of the true positive plus false positive. And if we talk about the negative predictive value, they have in the formula true negative divided by sum of true negative plus false negative. But now what we are going to find, we are going to find only positive predictive value. So let's find, I already told you, make a box like that. If you make the box or test statement in which diagnosis of a TB confirmed, diagnostically not confirmed, mean to say here we having the patient with disease and patient with no disease. This positive test result and with no positive test result. Okay, so they are a true positive, they are the false negative, they having the positive test, but they are not having disease. Okay, and this they're having false negative having disease, but test is not positive and they're having no disease, and test is not positive true negative. So we will make the values here. First we make the formula. What is the formula of positive predictive value? True positive divided by true positive plus true negative. Answer 700. The 700 divided by 700 plus 200. Understand, if you make a deviant here, it will go 0.25 and we're having the answer here, that is 0.25. If you in a small calculation, you can go with your calculators like 700, you have to divide with 200 and we have to cut 0 with the 0 and 7 with the 200. And like that. I'm not good so much in the math. I think it will be 7 by 200, it will be 1 by 4, and 1 by 4 is equal to 0.25. Oh, I done it. Okay, guys, now we will move to our next question. The next question is about a major outbreak of SARS-CoV-2 has reached pandemic levels, and the patient with infection are known to be contagious before clinical symptoms will. Infection control experts want to use a rapid diagnostic test that can identify what symptomatic patient who should quarantine at home for direct-to-consumer rapid diagnostic test with a similar cost degree of invasiveness and turnaround time have recently been developed. The characteristics of a test are summarized in the table. That these are a table going to summarize just A, B, C, and D based on this information and negative result of which of the following tests decrease the likelihood of having the infection most in this. We have to give the comparing the diagnosis with a similar sensitivity or test with a similar specificity like likelihood ratio are used to determine the relative clinical utility. So what we have to go to first about the likelihood ratio. The likelihood ratio is going to represent the probability of positive and negative test about the positive and negative test understand and in someone with the disease of interest over probability of a test result in someone without the disease. The likelihood ratio reflects how much more likely disease in a person with a given test result compared to their pre-test probability. The lower the value of the negative likelihood ratio, the larger the effect of negative test result in reducing the post-test probability of disease, and the likelihood ratio negative is calculated using the equation. We are also having two ratios for a likelihood ratio. One is a negative and one is likelihood positive. For the likelihood negative, like one person having no disease and they got the negative test results and they having reduced the post-test probability of disease. So we having the formula like 1 minus sensitivity divided by specificity. Specificity understand, and for the positive, and first we talk about this in this scenario, the likelihood negative of the test is we talk about this one specific, it will become the most common sensitivity is 8, okay, 85 or 90. Okay, and if you talk about specificity, there's a more having one is 90. If you compare this one is a more accurate test. Okay, so we will go with this, and they have a 1 minus 85 will do 0.85. Okay, and we will go with 0.9. When we will make a calculation in that, it will become 0.15, I guess, and it will be 0.9, and really answer will be 0.17 if you make a total of this, understand. So which is the lowest LR of the four tests if you make in the lag and likelihood ratio. And when the likelihood ratio is less than 0.1 indicates that the test is effective, ruling out the presence of disease. Understand, if you can focus the likelihood ratio is less than 0.1 or it should be greater than like that. It will be indicated as to the effect to the ruling out the presence of disease. If we are talking about the likelihood positive in this, we have to make the sensitivity above and we have to divide 1 minus specificity. Okay, but in this question they are asking over the negative, like based on find negative result of which are foreign to decrease the likelihood. So according to negative likelihood ratio, the most probably it is the most effective test is test number D. Right under test D, you can make more calculation for all the tests, but according to my experience and all the things, if you guys focus, these are two tests with the high sensitivity and there is a two test with high specificity. So what is the more accurate test have high sensitivity and high specificity, which is a more having the likelihood ratio for the more good to ruling out the disease, understand. So first of all, I go with this and I got obviously I got the ratio 0.17, that also giving a calculation of this. There is a standard in which it will be more than 0.1. So it will have an effective test that go to ruling out the presence of disease. Now we move to our next question. Our next question about the investigator that is conducting a 6-month incidence study of a new virus respiratory disease in the population of small town of 25 under resident. The virus seems to be infecting teenagers more often than others. This is the evidence that the virus provides long-term immunity after the infection has cleared the pure to the investigation. 150 residents had dwelled the disease, hundreds of whom were the teenagers during the assessment of the studies. The another 400 residents were diagnosed with the disease and freedom victim measure due to the following the incident of new disease of given time period. So in this question we have to calculate the incidence. If we talk about the incidence, the formula, all of the things we will talk about the cumulative incident. It is not a simple, this is a cumulative incidence in which we are going to calculate the number of new cases will be number of new cases that will going to divide by the number of people at risk. Understand, for this we have to get how many people get the new cases. The new cases in that 6 month is 400 in incidence. We are not going towards it is a teenager. We are just getting how many new cases are coming, and new cases are 400. So now we are going for number of people at risk. Mostly you will going for the formula. They will have to put in the total population in 200. That was a 6 month ago, understand, but in this 500 already 150 student, 150 residents are already infected. So if you make a subtraction here, so 2350 residents are on the risk because they are healthy. The 150 go to this is they are not on risk, they are already infected. So our calculation will become like this little bit tricky, and you have to use the mind, and our right answer is that 400 over 2500. Understand, and for the incidence, the formula is the number of new cases divided on number of people that is on the risk. Now we are moving to the next question. The next question is about the investigator is studying the association between exclusive breastfeeding and the body weight in infants. The body weight of the 15 exclusive breastfeed infant at the age of 6 months. Results are shown that patient and body weight that is given. All what we are going to do, one of the computed measure of center to density is kg, which is the following characteristics generally true about this measurement. Okay guys, you guys know the center tendency means Morty mean. They were saying in this all the calculation that were given in all this table, there is a one center tendency that is 6.8. If you get a focus, every value is just only one time. All the values is just one time. But if you focus on 6.8, it is two times. So repeated values I card mod. So 6.8k as mod. Now we have to find a correct statement about this measurement. First option, it is resistant to outliers. Of course, the mod and median are having great resistance to outliers. It value only occur once in data, no maximum time in the data. It is a 15th percentile of the set of values. No, it is not applicable for the quantity quality test data. No, it's a useful to assess the extent of no right answer. It is resistant to outliers because if you guys talk about the mod and median, there's a most resistive values against the outliers. If you talk about the mean is the most sensitive for outliers. Understand? Now we are moving to the next question. Our next question is about investigators studying the frequency of polycythemia in the population of remote mountainous region. A representative sample of 100 men show a normal distribution of hemoglobin concentration with a mean concentration of 17 gram deciliter and a standard error of a mean of 0.1 gram deciliter, which is following the closet estimate of the probability that the subject will have hemoglobin concentration greater than. Okay guys, if you guys know, they gave the value for mean 17 gram per deciliter with our standard deviation of plus minus is about the standard deviation of 0 deciliter. Understand? So normal distribution is the 1 gram in our normal days, and distribution of standard deviation of hemoglobin concentration is 1 gram divided by deciliter. In normal distribution, one standard deviation above and below the mirror covers, one standard deviation covers persons. So our mean having 17 gram deciliter. If you make one standard deviation, that means one standard deviation is the 1 gram per deciliter. It will become 18 or 16, understand? So 60% people are between 16 or 18. Okay, if you make the two standard deviation or more, they will add plus 2 or plus 3 gram like that. So it will be more than 18 and less than 60. How many left if you minus 68 from the 100? Then it will give you the value of 32, understand? So in this, on the normal distribution, if you divide in two parts, the 32%, it will be 16, the 16%. of participant or the patient having the value less than 16, having less than 16 and greater than 18, 16% having greater than 18, I think it's a little bit normal. If you guys focus, if anyone heading one standard deviation, then it will come in the 68%. In this question, they are asking how much probability of patient having the greater than 18 gram deciliter if 68% people having within 16 to 18, so 32% having probability that they will having less than 16 or more than. So we will make this 50-50. If you make 50-50 or divide it, then it will be 16%, means 16% people having the hemoglobin value more than 18. So the right answer will be 16%. Understand, it is all about our public health biostatic and epidemiology questions. See you in next session. Thank you.